Hello, everyone. Welcome back to Karan Academy. My name's Karan, and I hope you all are doing super well. Today, we're going to be talking about diseases of the pleura. Now, this is a bit of a bigger lecture. The three main kind of areas we'll be covering. First, you'll be pleural effusions. Now, this is a very high yield topic. I would hope you guys know this thoroughly. Then we have empyemas, which are infections of the pleural space, and then we have pleural plaques, asbestosis, mesotheliomas, all of those things. So let's start off with pleural effusion. So what is a pleural effusion? Well, as the name suggests, I'm sure you know that this is an accumulation of the fluid within the pleural space between the visceral and the parietal pleura. Now, this space ideally should contain very little amounts of fluid, which are meant purely for lubricative purposes. However, with pleural effusions, you have excessive levels of fluid in the space. For this lecture, I'm not going to bugger on about epidemiology or just going through the list of conditions. I think that's not useful. I think you can do that by a quick Google search. What I hope to get through is how these conditions and how this presents, how this would look on a physical exam, and then talking about the different types of pleural effusions and how we distinguish them and helping you have a system to differentiate between the different types. And then lastly, talking a bit about general principles of management. So firstly, I think before we jump into types, let's talk about how they present. Now, the severity is going to depend on the severity of symptoms is going to depend on the severity of disease. So if you have smaller pleural effusions, usually less than about 300 ml of fluid, you tend to be asymptomatic. This is because, well, you have a collection, but it's not big enough to cause any respiratory signs or respiratory distress. With larger effusions, you start to present with shortness of breath. Why? Because you're compressing on the lung and preventing proper expansion. You can have a dry cough as well as pleuritic chest pain. Now, the reason you get pleuritic chest pain is because this excess fluid starts inflaming or starts inflaming the pleura, and with the pleural inflammation, you get pleuritic chest pain. And as you know, pleuritic chest pain is pain that's worse on breathing in. In severe cases, you can actually have hemodynamic compromise, but this is very rare. And as you can imagine, with enough compression, you can prevent adequate perfusion to the heart. That's obviously not good. Clinical examination will reveal, firstly, asymmetric chest expansion if the pleural effusion is unilateral. I think that makes sense. You would get stony dull percussion notes. Now that contrasts to dull percussion notes, which are typically seen with pulmonary edema, which is commonly seen in things like congestive cardiac failure and pneumonia. Now, on paper, I talk about stony dull versus dull. I do think for the few cases that I have seen, you can actually tell a bit of a difference. I don't know if stony dull is the word to use. This just appears more dull. Well, why? Because with pulmonary edema and with our pneumonias, we have fluid that's kind of intermixed with lung parenchyma, intermixed with air, versus this is just fluid, which is why it's more dull. You also have reduced breath sounds compared to pulmonary edema, where you have increased breath sounds. And again, it's the same principle. When we listen over the part of the lung that has a pleural effusion, let's say if you're listening over right here, there is no lung here. It's just fluid. Versus if, let's say, there was a consolidation here, you are going to get better transmission because you now have fluid in this space, and it's within the lung, which is going to move and transmit breath sounds. The pleural fluid here is not going to do that because it's not going to be transmitting breath sounds regardless, because it's not lung. And then you can also get a pleural friction rub because of that friction between the parietal pleura and the visceral pleura as it kind of moves through. Okay, now I'm going to start off by confusing you and then making sense. These are a whole bunch of differentials, or sorry, causes of pleural effusions. Broadly, we have transutative and exudative. I don't know why I blanked there. So causes include CCF, cirrhosis, nephrotic syndrome. I'll just go over the important ones. Atelectasis, and then with exudative, we have parapneumonic effusions, malignancies, infections, and pulmonary emboli. This hopefully is making no sense so far. If it is, I'm sure you guys are, if this is already making sense and you guys are perfect, don't have to just leave at this point, please. But if it isn't, then perfect. Then that's exactly where I want you to be. Now, I talked about transutative and exudative. These are two broad mechanisms where you can end up with fluid in the pleural space. Why you get this fluid is very different in both of them. And therefore, if you understand what's going on, you can make that distinction much easier. Let's start off with talking about transutative causes. So don't read the text just yet. I'll just work through it. Let's say for some reason you have an increased tendency for fluid to move across the capillary membrane. Now, as you've probably done, as you've learned in cardiophysiology, the two factors affecting the tendency of a fluid to move across the membrane are going to be its hydrostatic pressure and its oncotic pressure. So now, if you have a situation where you have a normal capillary membrane, but fluid moving through, you're going to have either increased hydrostatic pressure or increased or reduced oncotic pressure. So again, if you have more pressure pushing on that capillary or less oncotic pressure pulling water or keeping your fluids in the vessel. Because you have a simple movement of fluid across a barrier, it is called a transutative process. In terms of increased hydrostatic pressure, you have things like congestive cardiac failure and portal hypertension that can cause increased hydrostatic pressure. Why does congestive cardiac failure cause increased hydrostatic pressure? Let's just think about that. So you have your pulmonary veins, right, which carry oxygenated blood to the left side of the heart. If you have left-sided heart failure, which is a common component of congestive cardiac failure, you are going to have a backflow, right? That backflow is going to apply pressure across the pulmonary veins and transmit it all the way back to the capillaries. And now you have increased backflow pressure, which is going to cause fluid to leak through. And then we have reduced oncotic pressure. With reduced oncotic pressure, for some reason, we have lost the proteins in the normal blood. These are mostly proteins like albumin, but also things like immunoglobulins. And the role of these proteins is to keep water in, right? And therefore, if you lose these proteins, you would start losing fluid as well through the capillary membrane. And causes of these include hepatic cirrhosis. Why? Because with hepatic cirrhosis, you have low levels of albumin, because albumin is one of the components or one of the things made by the liver. With nephrotic syndrome, you're losing so much protein that you are going to not have enough of it in your blood. And the same with chronic kidney disease, right? And now if I ask you, in most cases, is a transutative pleural effusion going to be unilateral or bilateral? I hope you'd be thinking at this point, well, Karan, if the issue is with albumin, albumin is going to be low everywhere, right? It's not going to be low in the left lung, but okay in the right, which is why most transutative pleural effusions tend to be bilateral and not unilateral. Let's talk about exudative. Now, instead of the issue being in the actual intravascular fluid, the issue is with the vessel or with the capillary. For some reason, you have an ongoing level of inflammation. This inflammation results in increased capillary permeability. Now, this is not something specific to the lung. It happens everywhere. If you have inflammation, you have increased capillary permeability. In normal tissue, this is to allow your white cells to basically attack and control the degree of inflammation or infection. But this in most cases is pathological here, right? Now, once you have increased capillary permeability, regardless of your hydrostatic pressure, regardless of your oncotic pressure, you're going to start leaking fluids into the pleural space, right? And note that the fluid itself is normal in these cases, right? It is protein rich. It is normal pressure fluid that's just leaking through. Now, on this note, do you think that these causes are going to be unilateral or bilateral? Well, let's talk about the causes. So as I said, inflammation, so things like pneumonias, TBs, empyema, all infections would cause inflammation, and therefore capillary permeability increased. Most of these are going to be unilateral causes, right? Next, we have malignancies. Malignancies also cause a low level of inflammation. And these can be the primary lung malignancies, mesotheliomas, or metastatic lung disease. Depending on how many lesions you can have uni or bilateral pleural effusions. And then we have autoimmune diseases, which you don't really need to know much about. And okay, cool. Now moving on to our initial investigation. So I hope this kind of helped you understand what are exudative versus transutative causes. I also want you to know whenever you see a pleural effusion, three things that should always, always, always be in your mind, red flag things, think about it, are congestive cardiac failure, malignancies, and infections or pneumonias. These are your top three causes of pleural effusions. Always consider them and always ask questions specific to each one of them. We can do an ECG, blood glucose, a dipstick, a urine collection if there is any, an FB, UEC, LFT, CRP, ESR. Again, if you just go 2 slides back, I don't want to waste time going through why. But again, if you just go through the causes we've talked about, all of these tests fit in with those causes. A thoracocentesis, or actually collecting the pleural fluid, serves two purposes. It can be both therapeutic as well as diagnostic. And we'll talk about the diagnostic part of it really quickly. And then with imaging, you can do a chest X-ray. And the typical finding seen on chest X-ray is going to be blunting of the costodiaphragmatic angles. And we have a few pictures of that soon. Before that, I want to talk to you about the light criteria for pleural effusions. Now, what is the light criteria and why should you care about this? The light criteria is a criteria that's used to differentiate transutative from exudative causes of pleural effusions. If you just have a pleural effusion and you don't know what's going on, and you want to, well, ask yourself, is this transutative or exudative? You cannot do that based on clinical examination alone. And therefore, we do a few things. So what we can do is so this is pleural fluid. So when we do a thoracocentesis, we can actually look at the pleural fluid and assess a few things. We can look at the level of protein, and we can look at the level of lactate dehydrogenase. And these two are the more important ones. So let's go back to our causes, right? As I said, with transutative causes, you have just the fluid that's seeping through a normal capillary membrane. Let's say if the cause was congestive cardiac failure, the proteins are going to be trapped in the vessel, right? Because the vessel is not dilated, the capillary spaces are not dilated, it's just fluid seeping through. Or if you have low oncotic pressure and you have low levels of protein anyway, again, the fluid that's leaking is going to be low in protein. Versus in exudative causes, where you have inflammation, you have inflammation, you have increased capillary permeability, where now you're not only going to leak fluid, but also protein. And therefore, what we can do is we can look at the ratio of the pleural versus serum protein level. And as you can imagine, in exudative causes, the fraction or the ratio is going to be higher than 0.5. Why? Because, well, the pleural fluid is going to contain more protein than exudative causes. And the same exact reason goes for lactate dehydrogenase. I hope that made sense. This is the light criteria. I don't think it's come up on exams hasn't come up on exams much, but I think it's an important question you would be asked on the wards, especially if you are on Gen Med or if you're on the RESP team. So know this. I think it's a good one to know, and I think it's very, very easy to know as well. Like, you don't have to put in any effort. 0.5, 0.6. If you understand what's going on, everything else makes sense. So let's go through a case, and we'll talk a bit more about the management styles in a bit. And I know that the answer and the diagnosis is a pleural effusion. So I'm sorry, but I really didn't have any other way to explain this. So we have a 72-year-old woman who's presented to the ED with a 2-week history of increasing shortness of breath and a cough. She cannot lie flat without feeling short of breath, history of hypertension and arthritis, and she feels very weak for the past few months. Oh, sorry, it's been a long day. And there's also a fly in my room. I don't know if you can hear that. It's annoying. Okay, so just based on this tiny history, what are some broad conditions we are thinking about? So pause and take a minute, think about this. And it's always good if you're actually pausing and writing down the list. It will help, I promise. You'll come to the end of the series, hopefully, and you'd say, oh, well, I think I know a bit more than I did earlier. And that's all we want. So some causes. of potential differential diagnosis lists. So cardiovascular include things like congestive heart failure, arrhythmias. Respiratory causes include pneumonias, APO, pleural effusions, pneumothoraxes, COPD, malignancy, bronchiectasis, TB, and fibrosis. Now, I want to note that you can have more than one thing happening at once, right? You can have a patient with chronic CCF who's now developed pneumonia, or you could have a patient with a pneumonia who also has a pleural effusion, right? It's not always the case where you have exclusively one, but for this case, it's going to be like one main one, probably. So let's dig a bit deeper. Because you are Monash students and you were absolute guns in pre-clin, you know how to take a really, really good history of presenting complaint. So her shortness of breath is, she says, 7 on 10, although ideally always try to assess shortness of breath based on exercise tolerance. Her current exercise tolerance is about 5 meters before feeling short of breath. Let's say her normal exercise tolerance was about 500. She's sleeping on 2 pillows and has frequent episodes of waking up at night. She has a dry cough throughout the day with nil hemoptysis and no sputum. Her vitals are relatively normal. She has a slightly high rest rate and a slight hypoxia, borderline hypoxia at 92%. She has no fevers, but has had a weight loss of about 5 kgs over the past month. In terms of her past medical history, she has a 25-pack-year history of smoking, no alcohol. She has hypertension and arthritis controlled by ACE inhibitors and PRN NSAIDs respectively, and has had no surgeries or past hospital admissions. She lives at home with her husband, is socially well, has not been in contact with anyone who has COVID and has not traveled recently. Physical exam reveals an impaired general condition, so she's generally unwell. Pulmonary auscultation showed hypoventilation in the basal and middle fields. The rest of the clinical exam was plumb normal. BP at this time was 144/80. O2 sat 95 on 2 liters of oxygen. So the fact that she's on 2 liters of oxygen and is still 95, which is okay but not great, makes us think that there might actually be a genuine respiratory pathology. The blood pressure is slightly normal, which may be normal for her, and we know she's taking an ACE inhibitor, Prindopril. Now, what do we do next? Some investigations. And again, we go through the exact list I talked about earlier. What are the findings? So an ECG rate of 86, mild right axis deviation, no bundled branch blocks. Her blood glucose is 8.6, and her last meal was about 2 hours ago. Urine dipstick doesn't show any nitrates, leukocytes, ketones, or glucose. And there is no sputum collection because she doesn't have any sputum, right? I've also taken this to show a few important things that I thought were relevant. Let me see, what did I think was relevant here? Okay, a few things I wanted to show. So this is a full panel of the test results we've come back. Let's start with the full blood examination. So things I'm looking for: could this be an anemia that's presenting? Her hemoglobin's normal. Her reticular distribution weight is 17.4, and that is not a parameter you should either know or understand because it's pretty useless in most practices. Next, let's look at her ABG that we took. Because we are worried about hypoxia, we took an ABG. Actually, this person has taken a VBG. But if you worry about hypoxia, do an ABG. If you're worried about acid-base stuff, you can do an ABG, right? And a few other things, if we look at her UECs, so she has a high urea, high creatinine, and a low EGFR, and a relatively slight increase in her CRP, which is not significant in itself. So what does this tell us? Well, not much really. Her FB is plumb normal. She has a bit of kidney impairment, which is not super concerning for someone her age, and her lactate's a bit high, although 36 might be borderline concerning at any age. We do a chest X-ray, and what does the chest X-ray show? Oh, wow, we can see what appears to be, so again, I'm going to take this and explain this as if I've never seen a chest X-ray in my life. There's one lung here, and then there is what seems like a part of a lung here. Well, I want it to be more of here, but this is all white. Well, what is white? Well, we know air is black and fluid is therefore white. So this person has fluid, and as I can see, I can kind of trace out the border. So she's kind of a fluid collection all the way up till here. I can't see the cardiac border. It would be stupid of me to even try comment on anything like cardiomegaly, rotation. Doesn't matter because I can't see it. I cannot see the costodiaphragmatic angles. And as we talked about, blunting of the costodiaphragmatic angles is specific for a pleural effusion. So this person has quite significant left-sided pleural effusion. Now, as I said, always be aware of the unilateral pleural effusion. Always be aware because it's most likely exudative, and we don't like exudative causes. So does this fit in with the clinical pictures? Always something you have to ask, because a lot of people have the tiny thing going on. Ask if it explains their symptoms. And I would say, yes, it could. This person is practically living off one lung, and I can imagine that being quite tough. So, as I said, what are the 3 leading causes of a pleural effusion that you have to think about? Please do not forget: pneumonias, malignancies, congestive cardiac failure. Now, just based on this, what do you think is most likely? It's a chronic history with a dry cough, with some weight loss, with some fatigue, with some shortness of breath, with some exercise intolerance, no sputum, dry cough. I would think it's a malignancy, right? And you can say that, like, there's no right or wrong answer here. It could very well be a pneumonia. It can very well be CCF, and I can make a convincing case for either. But at this point, malignancy is something I want to rule out, especially because the pleural effusion was unilateral, and that fits in with an exudative picture, and malignancy would present as an exudative pleural effusion. And therefore, we ask ourselves, what test can we do to establish whether this is exudative or transutative? A thoracocentesis, which will both help with symptoms and give us that information to assess her against the light criteria. So we take some pleural fluid. The protein in that is 3.6, and the serum protein is 6.9. We also have the fluid lactate dehydrogenase and the serum lactate dehydrogenase. If we then compare the ratio, we can see that the protein in the fluid, in the pleural fluid, is more than half of that of the serum. So half of this would be 3.45. This is 3.6. So it's more than half. So this is an exudative picture. And the same applies for serum lactate dehydrogenase and pleural fluid lactate dehydrogenase. We then also do cytology on the fluid, because often with malignancies, you can have kind of these cancerous cells floating around in the pleural effusion, but we don't see anything. Now, what process is this? Exudative. And because we're worried about malignancy, what do? We do a chest abdo-pelvis CT scan. That's the investigation you should consider. What does this show? So this is what you'd quite commonly see as a finding. And I've tried to keep this as clinical as possible based on what you would genuinely see on a CT report. A thoracic CT shows a massive left-sided pleural effusion, which pushes the mediastinum towards the right. A lung mass in the left lower lobe of these dimensions is found, which suggests malignancy, complete collapse of the left upper lobe, and partial collapse of the left lower and partial collapse of the left upper lobe. Multiple pulmonary nodules within both lungs, suggesting metastatic lesions, and several lymph nodes within the mediastinum. This is cancer, and is likely to be metastatic cancer, as suggested by the multiple pulmonary nodules. The main big one is the 6.9 times 4.5 times 7.6 mass, which is length, width, height. And that explains our pleural effusion, which, as we knew, was left-sided. Because this is metastatic disease, unfortunately, I can harp on about surgical versus chemo versus radio, but with a disease of this severity, our treatment is going to be palliative, and we're also going to have a greater emphasis on symptom improvement. So keeping a chest drain in, making sure that her pleural effusion gets better, because that is what's causing the symptoms, not the actual malignancy itself, right? Next, let's move on to a few other things. So we have asbestosis, pleural plaques, and mesotheliomas. So what are these? So these refer to a type of pneumoconiosis, which is a term you'd hear all about in your occupational health learning this year. And it's caused by long-term exposure to asbestos fibers. The key points you need to know about this, there are 3 types of asbestos, with blue asbestos or crocodilite being the worst. To develop asbestos, you need to have chronic high-grade exposure. So what I mean by this is you need to have years of exposure to asbestos. If you are exposed to asbestos for a week and next year you develop some symptoms, it is very unlikely to be asbestosis. And it also takes a long time to develop, about 20 to 30 years. On history, you would often find progressive dyspnea, orthopnea, and a chronic dry cough. And exam findings would show an expiratory wheeze, fine crackles, and clubbing. How do you diagnose this? Take a good occupational history, and I won't be going through this at the moment. Pulmonary function testing would often show a restrictive lung pattern, and then you can do a DLCO, which would show a decreased diffusion capacity. You can also do CT imaging, and we've talked about what CT imaging looks like for restrictive lung pathologies in our lecture on restrictive lung pathologies. And then we have mesothelioma. So what is mesothelioma? So mesothelioma is a cancer of the pleura that arises and is commonly linked to asbestos. It's not asbestosis. So asbestosis is the interstitial lung disease or pneumoconiosis. And then you also have mesotheliomas, which are cancers, but you don't have asbestosis progressing to mesothelioma, right? Both are independent conditions, independently associated with asbestos exposure. It often starts as a nodule in the parietal pleura, which then encases more cells, thickens, and then you end up with an exudative pleural effusion. And that's the most common presentation. So it's actually the signs and symptoms of their pleural effusion is what leads us down an investigatory pathway. You can also have nerves and lymphatics being affected. You can then do a chest X-ray, CT, and then do a biopsy via VATS and pleurodesis. So remove part of the pleura. However, mesotheliomas have a really, really bad prognosis with an average life expectancy of usually less than a year after diagnosing. So obviously, it's one of those really bad cancers. And what would this look like on imaging? So as you can see, we have our pleural plaques right here. Yep. As you can see here, highlighted in green, and this X-rays are taken from amboss. And these are bilateral pleural plaques that you can see. What does this look like under a microscope? So you can actually see visible asbestos fibers, which are these fibers you can see here. And on imaging, as you can see, this is really, really bad. You can see a pleural effusion because you've lost that costodiaphragmatic angle, and this is a malignant pleural effusion. Obviously, you can't call it a malignant pleural effusion just based on the X-ray, but we know what's going on. And always, as I mentioned earlier, beware of the unilateral pleural effusion. That's all we had for our pleural disease lecture. I hope that was useful. As always, any questions, feel free to send me a message. And as always, please look after yourself and please look after your loved ones.